I don't have any further witnesses. I guess I would like to make an offer of proof that's contingent, in a sense, on knowing the identity of the providers that were pinned on Exhibit H from the department. We don't know who those providers are at this time. I would make the offer of proof that Mr. Felgar could testify that there's at least one provider in Rochester, Terry Bennett, that has no privilege at Frisbie Memorial Hospital, and I'd like to make that part of the record. And then with respect to queries to Mrs. McCarthy about options with Assurant, another insurer offering marketplace or offering plans in New Hampshire, I would make the offer of proof that Mr. Felgar would testify that Assurant is not part of the list of carriers that provide insurance for Frisbie patients. So that wouldn't be an option for Mrs. McCarthy to preserve her Frisbie affiliated physicians.
So this is what you propose giving as an offer of proof?
Yes. What's that saying?
Excuse me.
Okay. He has no, Mr. Bennett has no usable privilege at Frisbie Memorial Hospital. Mr. Felgar would testify to that, and he would testify to the fact that Assurant is not one of the insurance companies on the list of carriers for Frisbie.
Comment from?
May I inquire? I'm not sure on the second point what it means it's not on the list. I'm not sure what that means.
Yeah, you'd have to explain what that means, Attorney, because I don't understand it either.
Shall I put Mr. Felgar on just
No,
to
you
explain?
can provide it to me as an offer of proof.
Okay, that's great. Essentially, Frisbie does not have a contract with Assurant.
Sure. Okay, thank you.
And can we have a clarification as to the time that we're talking about? That representation we made does not currently have one, didn't have one in 2013.
Assurant and Frisbie do not have a contract as of now and did not have one in 2013, is what Mr. Felgar would testify to.
Thank you. Is there anything else from?
I don't have any more testimony or exhibits that I would like to put in. I would like to reserve the right for some closing remarks if we have the time. Thank you.
I'm sorry, I didn't hear the end of what Mr. Eggleton said. Can you repeat what you said, please?
Just a second ago?
Yes.
I just want to reserve the right, if we have the time, to make some closing remarks. Other than that, I have no evidence or testimony I need to put in at this time.
I would ask the department if they have any witnesses to put on.
Well, just to be clear, so the petitioner's case is submitted?
Yes, the case is submitted. Again, I just want to reserve some time for argument that the case is submitted.
Your Honor, the department at this time would move to dismiss this proceeding without any further action by the commissioner. The issue before the commissioner today is a very narrow one. It's really in two parts. Did Mrs. McCarthy experience an injury in fact? And the injury in fact that she alleges is that she had to forego a subsidy on the federally facilitated exchange in order to retain her providers in through the Frisbie Hospital and Frisbie's contracted doctors. And the second part of that is, can the pathway network that Anthem has submitted to the department for recommendation to CMS can that network in Stratford County be deemed adequate? Should it have been deemed adequate by the department in its recommendation with the exclusion of Frisbie Hospital? And what we have heard from the petitioner who comes here this morning with the burden of proof. I mean, I realize it's a burden of more likely than not, but she has the burden, if you will, of moving those the scales of justice, in her favor. And the petitioner has demonstrated nothing this morning. What we've seen is that she's testified that all of her doctors that she sees right now through Frisbie are all located in Rochester. Okay, so she's in a very tight geographical area.
Let me stop you for just a
Yep.
second and tell you that I appreciate what you're saying, but that it is not my intent to dismiss this action at this hearing.
Then with that, Your Honor, I'll defer from further argument. I don't know if...
Well, just for the record, Mr. Hearing Officer, on behalf of Anthem, I was going to join in the motion to dismiss for the reasons that Mr. McCaffrey was going to set forth, because we don't believe that the petitioner has carried even her initial burden to demonstrate injury in fact, or that the Anthem network is inadequate for her use in Stratford County.
Again, as I said, it's not my intention to dismiss this action at this hearing, during the course of this hearing.
Then we'll proceed with the department's case. Alex? The department calls the Deputy Commissioner, Alexander Feldwebel. Mr. Feldwebel, if you have a seat right there, please, sir.
Okay.
Please state your full name and
Swear
please...
the witness in. You want to swear
You know
the
what?
witness in?
You're going to have to swear the witness in.
Would you raise your right hand, please? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth in the case now pending before us?
Yes.
Thank you.
Please state your full name and spell your last name for the record.
Alexander K. Feldwebel. My last name is spelled Feldvebel.
You employed Mr. Feldwebel?
Yes,
Where are you employed?
at the New Hampshire Insurance Department.
And what is your current position at the insurance department?
I'm the Deputy Commissioner
And how long have you served as the Deputy Commissioner?
since 2000.
And what was your position at the insurance department, if any, prior to your appointment as Deputy Commissioner?
Before that, for 2 years, I was the Health Policy Analyst for the Insurance Department.
And prior to serving as the Health Policy Analyst at the department, did you have any other position here?
No, not at the Insurance Department.
So you joined the department in approximately 1998?
Yes.
Would you please summarize your educational background as well as your professional experience that preceded your joining the department as the Health Policy Analyst in 1998?
I'm an attorney. I graduated from Harvard Law School in 1984, and then I practiced law for about 12 and a half years. For about a year and a half, I practiced in Texas at El Paso Legal Assistance Society, where I began to specialize in issues of access to health care for low-income people. Then I moved to New Hampshire and worked for New Hampshire Legal Assistance for about 12 years, again, focusing on access to health care and health law.
So is it fair to say that you've dedicated a large part of your professional life to issues involving the delivery of health care in New Hampshire, including health insurance?
Yes, most especially health insurance for the last decade or so.
As we know as insurance regulators, the world of insurance regulation can seem an arcane one to those who are unfamiliar with it. I'd just like to spend just a couple of minutes providing a little background as to what the insurance department does. And so let's begin. The state of New Hampshire, the Live Free or Die state, was the first state to create an insurance department in the United States.
That's right. Yeah,
Do you recall the year in which our department was created?
1851?
That would be correct. Does the department have a mission statement?
Yes, we do.
And have you committed it to heart?
Well, let's try. See now, the mission of the insurance department is to promote and protect the public good by ensuring the existence of safe and competitive insurance and a safe and competitive insurance market through the development and enforcement of the insurance laws of the state of New Hampshire, or something like that.
That's pretty darn close. Tell us what an insurance market is.
It's just a venue where sellers can come together with buyers for the purchase of insurance policies.
So at the farmer's market, people go and buy vegetables and maple syrup. At the insurance market, people buy and sell insurance policies.
That's right.
What does a safe insurance market look like?
Well, primarily, that means that the products that consumers are buying are reliable. That is, they're being offered by companies that are solvent, that have the money to pay the claims, and that the insurance company behaves in a way that is fair to the consumer. So all of the insurance laws that we enforce focus on basically those two things, the reliability of the coverage and the fairness to the consumer.
And with respect to on the company side, the most important thing being is that when a claim, whether it's for medical coverage or auto coverage or life insurance policy, that the company has the money to pay the claims when the demand is made.
Yes, that's what we refer to that as solvency regulation.
And there's a division at the insurance department full of CPAs who handle that.
That's right.
What is a competitive insurance market?
A competitive, well, there are a number of qualities of a competitive market, and a perfectly competitive market is actually pretty rare. But the most important qualities is that there be a lot of sellers and a lot of buyers, and that no seller or no buyer has the ability to easily determine price, that there's no barriers to market entry, so that the sellers can get into the market easily, that there's good information about the products, so that the buyers can tell what they're buying and make shopping comparisons, that there aren't significant transaction costs, that the products are easily comparable, and that there aren't economies of scale for the sellers that tend to make the sellers larger and larger and fewer in number. So those are all qualities of a competitive insurance market.
Is it accurate to say that the federally facilitated marketplace or exchange is a subset of a larger health insurance marketplace?
Yeah, the way we define insurance markets for health insurance regulation is really by the buyers. So we have the individual market, where the entity that's buying insurance is an individual, and we have what we call the small group market, where the buyer is a small employer, and a large group market where the buyer is a large employer, that is above 50 employees. And the New Hampshire Exchange, or the marketplace you refer to, is one form within the individual market and within the small group market where buyers can purchase coverage, but their buyers can also purchase coverage outside of the exchange in the individual market and in the small group market.
Now, is it fair to say that in New Hampshire that some insurance markets are more competitive than others?
Absolutely.
What would be an example of one of our more competitive markets?
Homeowners insurance, auto insurance, life insurance, lots of sellers, good information about the products. They're homogeneous products, easy to compare and evaluate, and nobody, has enough market share to control prices.
And what would be one of our less competitive insurance markets?
Health insurance, and I would say medical malpractice coverage as well.
Can you explain to us why, let's talk about the health insurance market here. Why is the health insurance market less competitive, say, than the auto market?
Well, the primary reason that there are big barriers to market entry for an insurance carrier, a health insurance carrier, to come into the state. And that's because these days you can't offer health insurance competitively without having a set of provider contracts with hospitals in the state, physician groups, other specialists, and the cost and the ability to negotiate for provider contracts that will make for a health insurance product that's competitive it's very difficult to achieve for an insurance company just coming into the state. Remember, I mentioned earlier, one of the qualities of a competitive market is that there aren't economies of scale, so that the bigger you get, the more advantage you have. Well, in health insurance, there really are economies of scale. So the bigger the health insurer, the better a deal it can negotiate with hospitals and physicians and other providers, because it can deliver more covered lives, patients, to that entity. So it's a market that tends to have fewer and larger entities, because those are the only ones that can compete.
I guess it's obvious to say the insurance department itself would be delighted to have dozens of health insurance companies operating in this state within our insurance laws, right?
Yeah, we want enough companies for the consumers to have choice of the products that they desire. But we also want those insurance companies to be good negotiators for discounts with the hospitals and the physicians that they have to negotiate with. So we want them to have enough market power to get those discounts.
Now, you understand that there is a particular provider network that is the reason for this hearing this morning, and it's the adequacy of the network that associated with Anthem's federally facilitated marketplace plans, right?
Yes.
Mr. Feldwebel, I don't know if you've met Mrs. McCarthy before, but Mrs. McCarthy is sitting just behind you, and you know that Mrs. McCarthy is the petitioner here today?
Yes, I do.
And did you hear Mrs. McCarthy's testimony earlier today?
No, not today.
You were sequestered?
Yes.
But you've read the petition in this case?
Yes.
Now, what do you understand to be the substance of Mrs. McCarthy's petition?
I understand that she would like to have two things, really. She would like to have, and two things at the same time. She'd like to have access to the tax subsidy that's available when you buy health insurance through the exchange. That's something that happened with the Affordable Care Act. And she'd also like to be able to pick a health insurer that has her hospital and her doctors in the network, and that's Frisbie Hospital and Frisbie Doctors. I think she has a long relationship with those doctors, at least 15 years, and she feels loyalty to those doctors. So she values having those doctors in the network, but she also values the subsidy that's only available in the exchange. She'd like to have both things.
Without having to make a choice between them.
Right.
What is your understanding, if you have one, of why Mrs. McCarthy's providers were not included in Anthem's Pathway Network?
Yes. My understanding is that Anthem, in making their business decision about how to approach this new venue for selling insurance, decided, based on their research into what consumers mainly wanted, that the most important thing is to go for a low price, and that more consumers these days are interested in saving money on their premiums than in having a particular doctor or hospital in their network. So that was their business strategy, and most effective tool, it turns out, that you have as an insurance company for getting a lower price is to offer a network of hospitals that's more limited than one that includes all the hospitals in the state.
Now, earlier today, at the beginning of the proceeding, the commissioner, the presiding hearing officer, indicated that he was taking judicial notice, formal notice of all of the pleadings in the case, including the proceedings from what was I guess it was an AR case, but going back to the original case, the petition of November 6th of this year. And in those pleadings, and in other places, but in those pleadings, Frisbie has alleged that it was willing to accept, it alleges it was never asked by Anthem to participate in its pathway network, and had Anthem approached it, Frisbie would have accepted the same rates that were being offered by Wentworth Douglas to Frisbie. Is there it's kind of a matter of like a logical syllogism? Is there a piece missing in that argument that Frisbie's been making for months in this case? And if there is, can you identify it for us?
Yeah, it's that component that I mentioned about 5 minutes ago about an insurance company's bargaining power in bargaining for discounts, that they have to have a large number of covered lives that they can deliver as patients. And for Anthem's strategy to be successful, they felt that it was important that they be able to deliver more patients to those hospitals and physicians that were in the network. But that's what the bargaining chip that got them the discount on prices. So if they just took any hospital that accepted their reimbursement rate, the whole system for getting the lower rates long-term would be undermined.
And more specifically, the discount that Wentworth Douglas gave to Anthem was a discount between 25 and 30%, right?
Yes. Anthem has said that the premium savings that they achieved with the more limited network was between 25 and 30%, and research about other limited networks across the country shows the same thing.
And that discount is based on the increased volume of business at Wentworth Douglas.
Yes.
Mr. Hearing Officer, at this point, I'm going to object only as I'm taking the position that I let this line of questioning go, but I don't understand the relevance to the issues that we're here on today, which is focused on Stratford County.
We'll move on. Mr. Feldwebel, what statutes govern network adequacy in New Hampshire, or rules?
RSA 420J, the managed care law, addresses network adequacy, and then we have a rule, INS 2700, that also addresses network adequacy.
And New Hampshire's network adequacy statute is it's one section of a larger law called the managed care law.
That's right.
And the whole managed care law is contained in Chapter 420J of our statutes.
That's right.
When did New Hampshire's managed care law, including the network adequacy provisions, first go into effect in New Hampshire?
It went into effect in 1998.
Now, you joined the department in 1998. Did you have any hand in drafting the actual managed care law, 420J?
No, that was before my time.
Now, President Obama signed the Affordable Care Act into law in March of 2010, right?
Yes.
So the managed care law here in New Hampshire predated the Affordable Care Act by about 10 years, I guess, more than 10 years.
That's right.
Now, Section 420J7, that's a section that deals with network adequacy, right?
Yes.
Now, that section directed the insurance department to develop administrative rules setting forth the standards for network adequacy, right?
That's right.
And was the rule eventually developed and adopted?
Yes. I think it went into effect in 2002.
And the rule is found at INS 2701, right?
That's right.
Did you have any hand in drafting INS 2701?
Yeah, I actually, I wrote the first draft of it, and then I was around as it was being reworked with the working group that the department put together.
Who else, if anyone, was involved in drafting New Hampshire's managed care law, including that network adequacy section?
Well, if we're talking about the rule, the network adequacy
Talking
rule,
about the rule now, yes.
Yeah. We put together a working group of all the stakeholders who had any interest at all in the network adequacy rule. So our working group included the Hospital Association, the Medical Society, physicians, community health clinics, mental health providers, consumer advocates, and of course all the major carriers also participated in that rule development.
And you've indicated that the law was eventually, this rule, after this process went forward, was eventually formally adopted. I think your testimony was in 2002.
Yes.
So again, that would be several years before the Affordable Care Act went
Yes.
into effect.
Yes.
Yeah, and just for council, and we'll provide smaller copies of this. We'll probably get those to you today. It's just a chart that's reflecting the, sorry, James. The chart here, Mr. Feldwebel, reflects the legal citations for New Hampshire's statutes and rule that concern network adequacy, right?
Yes, that's right. The 420J7 contains the basic network adequacy requirement. J12 contains the rulemaking authority, and then 2701 is the actual rule that we promulgated.
And the effective dates of the statutes is indicated on
Yes.
the chart, right? In its broadest terms, Mr. Feldwebel, what does network adequacy refer to?
Well, it refers to the underlying fact that when you buy a managed care plan, you're having your access to healthcare providers limited. Okay, and so your access is limited to providers who are in the network. So, and that started happening in the early 1990s. So eventually, once managed care was around long enough, each state developed rules like this one for network adequacy. And the idea is, if your access is going to be limited, let's make sure that the network of healthcare providers that is under contract with that health insurance company is meets some minimal adequacy standards. It's like a floor or a threshold requirement, minimal requirements to ensure adequate access to care without unreasonable delay.
Now, in order for a given insurance company's network to be adequate, what do RSA 420J and INS 2701 require?
420J just sets out that basic access requirement, which says that health insurers have to contract with a sufficient number of providers, sufficient number and type and geographic location of providers to ensure that that healthcare covered services, that is, are accessible without unreasonable delay. That's all that's in the statute, is that general standard. And then it's left up to the rule to flesh out that general standard. So would you like me to describe what's in the rule?
Yeah, sure, please.
The rule, the heart of the rule is these geographic accessibility standards. And it applies county by county, and the requirement is that the covered persons in that county have access to different provider types within certain mileage limits or travel time limits. And so, for example, for primary care providers, there has to be at least 2 open panel providers. I think it's within 15 miles or 45 minutes of 90% of the covered people in that county. And for hospitals, the distance standard is 45 miles or 60 minutes travel time. So those are the geographic access standards in the rule that form really the heart of the accessibility requirement. But there's also a provision regarding waiting times for appointments. That is the time between when you call for an appointment and when your appointment actually happens. And there are other requirements in the rule, such as annual reporting provisions, transparency, posting your network, and some enforcement provisions.
How does the insurance department determine whether or not a particular company's network is adequate? And when I say adequate, I mean, I'm referring to in compliance with RSA 420J and INS 2701.
Well, traditionally, we did it one way, and then subsequent to the Affordable Care Act, we did it in a somewhat different way. But I'll start with traditionally before the Affordable Care Act. We did it as part of our market conduct review function, which is, that's a unit within the insurance department that looks at how carriers are behaving in the marketplace to ensure compliance with the laws. And we would receive the initial certification of compliance and then the report, and look at the report. We would pay attention to whether there are any consumer complaints or anything that would lead us to believe that there's a compliance issue. We might do an exam if we think there's some kind of issue. But it was reviewed as a market conduct function based on an existing population of covered lives. So the question for us is, how many people have already bought this policy, have it in effect, and do they meet those mileage and travel time standards? That's the main kind of review that we would be doing.
Now, you've used the term a couple of times. You referred to market conduct, and just so we're clear, that market conduct among insurance regulators has a very specific meaning, right?
Yes.
And there are actual, for each line of insurance, the National Association of Insurance Commissioners issues, there's a handbook, and within that handbook there are examination standards for each line of insurance, correct?
That's right.
And we have over here at the insurance department an actual group of market conduct analysts and examiners.
Right.
So when you say market conduct, that's with a capital M and a capital C, and it kind of refers to a subspecialty within insurance regulation. That's
right.
All right.
Right.
So that's what was done. Is that traditionally?
Right.
So in 2010, right, we have the Federal Patient Protection and Affordable Care Act enacted in March of 2010, right?
Right.
And then, what did you see here, I have NH 4 RSA 420N8. That's a New Hampshire law?
Right.
With an effective date of 6/18/12, correct?
Right, right.
So, please explain how these two items, the Affordable Care Act that was enacted by the federal government, and then RSA 420N that was enacted by the New Hampshire State Legislature. Please describe what impact, if any, these had on the department's review of network adequacy in New Hampshire.
Sure. So when the ACA was passed in 2010, it set up this process where there were going to be exchanges available in January 1, 2014, where people could go buy insurance and get the financial assistance through the tax subsidy to pay for the premiums. And the question for New Hampshire was, the New Hampshire legislature, that is, are we just going to let the federal government come in and run the thing totally, or are we going to have some role in it? And what the legislature decided is that we would have this partnership exchange, which is basically an exchange that's run by the federal government, but in which the state insurance department continues to perform its traditional regulatory role, even for those products that are being sold through the exchange. So that was RSA 420N. That was the legislature, when they passed RSA 420N, they said, we'll let the federal government come in and basically set up the shopping experience, the website, and all that. But our insurance department will continue to review and regulate the policies and the carriers that are offering coverage in that exchange. And the 420N specifically said one of the traditional functions that the insurance department will keep is the review of network adequacy.
So when 420JN tells the department, instructs the department that, oh, we want you to continue to review network adequacy, did it provide a new network adequacy law which the department could then use in evaluating a plan or a membership and plan that did not exist and plans that had not been sold yet?
No. We just referred to the fact that we were to keep our function of continuing to enforce the network adequacy law and regulation.
So what we were, the department was effectively, or what effectively happened with the ACA and RSA 420N, these new laws were essentially overlaid over our existing statute, which was, preceded the ACA by 12 years, and the rule which preceded the ACA by 8 years.
Right, right.
But we weren't given any specific direction how we were supposed to fit the round pegs of these new laws into the square holes of our old laws.
Yeah. Now, it wasn't too difficult. The main conundrum was how to apply the network adequacy standards prospectively. That is, before the product was being sold, because as a part of this partnership function, the insurance department had the role of reviewing the plan filings, the proposed products that were going to be offered on the exchange. So we received those filings and we reviewed them for compliance with New Hampshire law and with federal law under the ACA. And one of those upfront review items that we had to address was network adequacy. So the only conundrum was that our network adequacy regulation says that the standards for network adequacy only apply in each county where there's at least 1,000 lives. So if they're less than that, they've met the network adequacy standard because there are no requirements. But in this instance, there couldn't be any lives because it's a new product being offered in a new forum. So what we did was to require the carriers to show that they meet the network adequacy standards for their existing population in the marketplace outside of the exchange.
Was that done?
Yes. That's what we required Anthem to show.
If, whether it's a federally facilitated marketplace network, or it's a non-ACA network of providers. If the department were to look at a network and determine that it was inadequate in a particular county, what's the remedy that the department has in that situation?
The primary remedy is to prohibit the carrier from actively marketing that product in that county. We also, in the statute, have the ability to require some sort of corrective action plan. And sometimes we use that if there's already an enrolled population in the county and there's a contract dispute with a hospital that has a big impact on the members in that county. We would typically require the carrier to submit a corrective action plan, which would mostly address people who are in course of treatment and how they're going to be taken care of throughout the course of treatment, things like that.
Does either of our network adequacy laws, 420J7 or INS 2701, allow the insurance department to dictate to an insurance company, say Anthem, that it must contract with any particular hospitals, providers, or other medical providers or services?
No, we don't have that authority.
So the corrective action that you were describing a moment ago, that would, if that were to be the remedy chosen if that network were inadequate, ordering a company to contract, that's not an available remedy.
No.
And that's just not available as a matter of New Hampshire law, right?
Right.
Do either RSA 420J7 or INS 2701 require that an insurance company's network cover every patient in every service area?
Are you referring to the geographic accessibility standard?
Correct, I am, yes.
Okay. No, the way the standard works is that, let's say it's 45 miles for a hospital. 90% of the covered persons in that county have to have access within that 45-mile limit. So not 100%, but 90%.
So it'd be very difficult, even looking at any particular, impossible, looking at any one particular consumer who could show that he was outside of, say, the 15-mile requirement for primary care physicians. The fact that there was one person out there within a service area who doesn't have geographical accessibility, that in and of itself would not mean that the network is inadequate under our law.
No, it's a population-based standard, and you have to look at the whole population of covered lives in that county.
So you could have as many as a maximum, I guess, of 10% of the population outside the geographical access requirements specified under 2701,
right,
and still have a network that's adequate. Is that what you're testifying to?
That's right.
Now, you understand that Mrs. McCarthy resides over in Rochester in Stratford County?
Yes.
And so for network adequacy purposes, is it accurate to say or not that Mrs. McCarthy's service area is Stratford County?
Yeah, that's right.
By the way, Mr. Feldwebel, is there a point, because the ACA is a federal law, where Commissioner Savini's authority stops due to federal preemption? His authority with respect to network, the issue that brings us here with respect to network adequacy and the ACA plans?
Well, the way preemption works is there could be a point where the Commissioner's authority stops. And we try to avoid that by ensuring that we harmonize state law with the federal requirements. So long as our network adequacy standards are in harmony with the federal network adequacy standard, then the commissioner remains the sole authority enforcing that standard. Does that make sense?
Did to me.
Okay.
Hope it makes sense to the commissioner. Just putting a board, we're not marking these as exhibits, these are just for demonstrative purposes only. But I'm putting a board in front of you that we see forms and filing, and then under the word prospective, and then on the other side we see market conduct, which we talked about a moment ago, and retrospective. And when you were testifying earlier about the traditional way that our network adequacy law was used and how that was applied, and how the certifications were considered by the department, you were talking about that being a market conduct function.
Right.
And that is sometimes referred to market conduct as a retrospective function. You've heard it used in connection with that?
Yes, yeah.
And can you explain in what sense is market conduct insurance regulation work retrospective?
Well, when we're doing a market conduct review, we're always looking in the rear view mirror. We're looking at how an insurer has behaved with respect to its insured population over a period of time that goes at most up to the present. And we often look at files, underwriting files, or we'll interview consumers to find out whether there has been compliance or not in the past.
And so let's unpack that a little bit. So when say an examination is called, market conduct examiners actually select a specific period of time and say the examination is for the period of X to Y, and those will be, it could be a year, it could be 2 years or 3 years, right?
That's right.
And these are years in the past, and they go back, and what they take a look, and correct me if I'm wrong, they compare they can go visit the companies on site, they can do it electronically, it's usually a combination of both, I guess, but they're looking backwards.
Right.
And determining whether compliance existed in the past.
Right. With respect to in-force coverage.
Right. And by in-force, you mean coverage that existed in that time period.
Yeah.
Now, on the other side of the board here, we see forms and filing.
Right.
And like market conduct, that has a very specific meaning to insurance regulators like us, right?
Right.
Could you explain, what forms and filing is within the context of insurance regulation?
Okay. Well, that's a process where we have forms examiners at the department look at basically every policy, every insurance policy that's going to be sold in the state, and we approve it as being in compliance the way it's written with the insurance laws before it can be sold. So it's prospective in that sense. You can't sell it until we've approved it. And we're looking at the products they want to sell and ensuring that they comply with New Hampshire law.
So take a Geico auto policy. Let's pick on Geico because they advertise a lot. So if Geico has a new auto product that they want to sell in New Hampshire, there are going to be forms like the policy itself and the application that are associated with that.
Yeah, and maybe an underwriting manual or something like that. Yeah.
And
Advertising.
that would talk, advertising, all these things get reviewed by someone here at the department.
Yes.
And before, for example, that advertising of that policy can be used, it gets submitted by Geico to the insurance company.
Right.
I mean, the insurance department.
Insurance department.
And we have a unit, and it used to be called Forms and Filing, and now we call it the Compliance Division.
Yes.
So our compliance folks review all of that data before it can be used.
Right.
And so they're looking down the road and saying, okay, does this conform with our law? And until they say it can be used, it can't be.
Right.
And there will be, you mentioned that with the retrospective look, there are in-force policies during the period that's looked at. With the prospective look, there are no in-force policies.
That's right.
Right? So to go back to the chart I had earlier with the, showing those the four statutes and the one rule, our network adequacy laws, 420J and 2700, they were written back in this world of market conduct and retrospective, isn't that right?
Right.
But when the ACA came along and there were no members and no plans that had actually been sold, that was more like prospective.
It had to be prospective because one of our functions was to make recommendations as to which plans should be certified as qualified health plans in the New Hampshire Exchange. And we had to do that months, about 6 months, before those policies were going to be sold. And one of the criteria for being certified as a qualified health plan was network adequacy. So we had to take the filing, look at what the network was, and then assume a certain covered population in order to run those geographic accessibility standards. So that's what we did. And we only applied the geographic accessibility standards. We didn't do waiting times or any kind of review of consumer satisfaction because those things couldn't be done before you have an enrolled population. So we just limited ourselves to the geographic accessibility standards, and we assumed an enrolled population that we felt we were pretty confident was going to be larger than the actual enrolled population.
So what, in this case, Anthem had to show for purposes of network adequacy is that 90%, and we're talking about Stratford County here, that 90% of the members in Stratford County had the required geographical access to their mental health providers, their other medical providers, and the health facilities.
Right.
It's really a pretty simple analysis when you get down to it.
Yeah, there's reports that are generated by a software program. I think one of them is called GeoAccess, and it has a little map with dots on it and the percentage of covered persons in that county who meet the standard.
That's a software program that's used by health insurance companies in the industry.
Yes.
Mr. Feldwebel, at the time the insurance department or sometime after the insurance department through 420JN knew that it was going to be partnering with the federal government, with the implementation of the Affordable Care Act here in New Hampshire. Did the department issue any sort of guidance to the carriers who might want to come into the plan?
Yeah, we put out a bulletin, I think sometime in March of last year, because the filings were due in June. This is something that we do a fair amount. We put out bulletins that basically explain to the carriers how we're going to interpret the law and enforce the law.
All right, well, let's take a look at the, I would direct your attention to what has been introduced into evidence here this morning as NHID Exhibit F. It's at tab F, and the first page of it appears at page 224. And you have that in front of you, Mr. Feldwebel?
Yes.
You recognize this document?
Yes.
And what is it, please?
It's the bulletin that we put out in April, actually, in 2013, explaining to the carriers how we were going to conduct our review process for qualified health plans. And it set out a schedule, a timeline for how it's going to be done, and it has a chart with the different federal standards and state standards that we were going to be applying in different categories of regulation.
So, is it common for the department to issue bulletins?
Yes.
And the bulletin that's been marked as Exhibit F, it dealt generally with these qualified health plan certifications,
Right.
not specifically with network adequacy.
Right. It was basically our way of telling any interested carrier, that is, any carrier might be interested in offering a plan for the 2014 plan year on the exchange, how we were going to do the QHP review.
But network adequacy, was it reviewed in this or
Yes.
considered in this?
Yes.
I'm looking at page 227 of Exhibit F.
Right.
Is that where it's dealt with? Is it? And also on to the following page, 228.
Yes, that's right. Yes.
So,
I'm having a hard time reading. This must have been copied a few times. Yes. Sorry.
Can you read it?
Yeah, it's pretty dark, but yes, that's the right page number.
Well, what did the, and if you can't read it, my copy seems pretty legible, so I want
No,
you-
just the title on network ads.
What did the April 10th, 2013 bulletin require insurance companies to do in order for their provider networks to meet New Hampshire network adequacy laws?
Well, our bulletin just articulated the basic standard that's contained in federal law, the basic access requirement, and it laid out the one element of network adequacy that's contained in federal law that wasn't already provided for in state law, which is access to essential community providers. And those are providers like community health clinics who serve people, the traditionally underserved populations. And part of the federal standards was that there be enough access to essential community providers. So we addressed that, basically referencing the federal standard for how many ECPs had to be in the network in a given area. And then we referenced our existing law and rule.
And if you look at page 229, 2/3 of the way down, do you see a column on the left that says New Hampshire Insurance Department Certification Procedure?
Yes.
And that says NHID will allow QHP issuers to choose their service areas, except that requested service areas may not be smaller than a county.
Yes.
So what does that mean?
That's just consistent with how we've always administered the network adequacy requirement, which is that a carrier is not required to immediately come into New Hampshire and offer a product statewide. It could offer a regional product with a network that's limited to a region, but made clear that we're going to apply our network adequacy standards county by county, and that you can't move into just part of a county.
At the time the April 10th, 2013 bulletin was issued, did the department know that Anthem would be the only carrier offering plans on the federally facilitated exchange in 2014?
No, we didn't know it at that point.
When did that fact finally become known?
Very late. We probably sometime in August. We had hoped that there would be a multi-state plan, and that's a process that under the Affordable Care Act is administered by OPM.
OPM is?
Office of Public Management. Or
That's a federal
Yeah, it's a federal agency that administers health coverage for all federal employees, and under the Affordable Care Act, they were supposed to arrange for there to be at least 2 multi-state plans in every state, but they were allowed to stage that in, and we were hoping to be one of those states who got one in the first year.
But that did not happen.
It almost happened, and then it didn't.
And when you mentioned the time frame of August 2013, the New Hampshire, the federally facilitated marketplace here in New Hampshire, it went online. It opened up on October 1st.
Yes.
Just a couple of months later.
Yeah.
Does the New Hampshire Insurance Department have the ultimate authority to certify whether it's Anthem's network for use on the exchange or any other company's network? Do we have the ultimate authority to certify these networks for use on the exchange?
No, we don't, because it's a federally facilitated exchange, and under the partnership arrangement, all we do is make a recommendation for certification. So we went through our review process and then made a recommendation, and then CMS, or under that CCIO.
CCIO is?
The Center for Consumer Information and Insurance Oversight, which is the division within CMS that
CMS is Center for Medicaid and Medicare Services?
That's right. Sorry.
So they, with those...
They run the exchanges, and they're the ones who made the call on the certification.
So it's ultimately their authority, their call. What is the National Committee for Quality Assurance?
That's a private, nonprofit entity, and their mission is to assess the quality of services of managed care organizations.
And to go back to the alphabet soup, the National Committee for Quality Assurance is generally referred to by folks
like me,
like us, regulators, as NCQA, right?
Mm-hmm.
All right. Now, what relationship, if any, is there between NCQA and New Hampshire's network adequacy laws?
We refer to NCQA standards in our network adequacy regulation when in that section referring to waiting times for appointments. We say that if it meets NCQA accreditation standards, then you're in compliance with New Hampshire network adequacy law.
Well, when you say meets NCQA accreditation standards, the standards that NCQA applies or they review, aren't they actually standards that are created by the carrier itself?
Yeah, the carriers, in this process between NCQA and the insurance carriers, they're allowed to a certain extent to define the standards, but
they being the carrier.
The carrier, yeah, that they're going to meet and then demonstrate that they meet them. But those standards have to be sufficient to meet NCQA's standards. That is, NCQA won't certify anything.
Do you know if Anthem Blue Cross Blue Shield is meeting the NCQA standards in New Hampshire?
Yes, they are.
I would direct your attention, please, to what's been marked as NHID Exhibit G, which is in Volume 3 at page 235. Take a look at that, please. Tab G, which is also Exhibit G.
Yeah.
You recognize
Yeah,
that?
that's the certificate of NCQA accreditation. It says that Anthem has the highest accreditation status of excellent. And it's for the period of March 21, 2012 through March 21, 2015.
You know, below excellent, it says they have the highest accreditation status of excellent for service and clinical quality that meet or exceed NCQA's rigorous requirements for consumer protection and quality improvement. And then on the next line, I want to ask you, because again, we get lost in this alphabet soup. It says this organization's HEDIS results are in the highest range of national performance. What, in HEDIS for the record is spelled capital H, capital E, capital D, capital I, capital S. What is HEDIS?
I don't know what the acronym stands for anymore because I've just said HEDIS for so many years, but it's a number of quality measures that have been developed by NCQA, and they're pretty standard. And there are things like, do patients who have heart attacks typically get beta blockers within 24 hours of entering the hospital? Things like that, quality of care. And there are also consumer satisfaction measures that are used. So that's what HEDIS is about. It's a bunch of uniform quality measures so that carriers can be compared to one another in terms of the quality of their services.
But it's these are meaningful, if standard is the right word, but these are meaningful standards within the health insurance industry, is that right?
Yes.
Okay, and again, this indicates that Anthem's results during this period of March 2012 and the certified through March 2015 are in the highest range of national performance?
Yes.
I have no further questions.
We all set, Commissioner? Apologize.
It's all right, whatever.
Mr. Feldnabel, my name is Jeremy Eggleton. I represent Mrs. McCarthy, and I work for Orr and Reno.
Hi.
You had, just as an opening question, are you personally familiar with the materials that Anthem submitted to the department for the purposes of establishing network adequacy for its pathway network?
No, I didn't review those materials.
Have you reviewed them in the context of this petition by Mrs. McCarthy?
I think I've seen a few pages of the submission.
But you haven't looked at the entire submission?
That's correct.
Okay. Are you aware that we filed a RSA 91A, Freedom of Information Act, similar request for documentation that would be related to Anthem's network
Yes.
adequacy filing?
Yes.
Okay. And have you had an opportunity to look through that material at all that was produced to us in response to that request?
No.
Okay. So you basically haven't looked at any of those materials at all. Earlier you talked about the business decision that Anthem made concerning the trade-off, I guess you put it, between low price versus a broader network. Do you remember that?
Right, yes.
And you said that you were talking about that business decision with some familiarity. At what point did you learn that that was the way that Anthem approached this issue?
Mr. Commissioner, I'm going to object to this line of questioning. Again, this is irrelevant, as I objected similarly to Mr. McCaffrey's line of questioning to what the issue is here in this case.
Could you state what the issue is and
Well,
where you're trying to go with it?
I do appreciate that, but the door was opened at least as to the point where the testimony had stopped. I think I'm permitted to ask some questions about that.
Up until where it was stopped.
Okay, thanks. So at what point did you learn that that was Anthem's strategy for approaching this new network?
Objection again. I think the use of the word strategy there, unless he can establish that this witness has personal knowledge of strategies, I think that it's hearsay.
How did you learn about the testimony that you gave concerning Anthem's decision, its business decision? I think you called it.
Yeah, it was.
I also want to object, Commissioner, that they're certainly under, in the time frame that any such discussions were going on, those are confidential discussions. Those are not discussions that would be made public at that time of the process. And I think this witness can verify that, but I renew my objection as well. This is far afield and is irrelevant to what the issue is in this case, per your March 28th order and your decision on the motion to eliminate.
My response is just that Mr. Feldwebel has been permitted to testify up to a point about a number of things that I think are of interest here. They certainly were relevant from the perspective of the department when it began asking these questions. And therefore, it would be a denial of my client's rights to not permit me to cross-examine the witness as to his prior testimony.
Just on that one point, my understanding of the testimony was that this witness was, when made reference to statements, statements made in the public. Now counsel here, and I see the witness is nodding, counsel here is attempting to go into proprietary and confidential discussions, both from Anthem's perspective and the department's perspective under New Hampshire law, as opposed to inquiring about his knowledge of reading statements made in the public. To the extent that counsel is looking to do that, I don't think that it's intruding on anything that's confidential if it was made statement publicly. However, I still maintain that this is far afield and is going to take up the Commission's valuable time in trying to get through this this hearing. So I object.
I'd like the witness to simply answer the question from the standpoint that the witness has personal knowledge and not hearsay.
Sure.
How did you learn of the department's business decision, as you called it, to seek a less broad network for a lower price?
I learned it from listening to Lisa Gurdon at the presentation that she made before the New Hampshire Senate after the network adequacy provision, or the network adequacy recommendation had been made by the Insurance Department, and the issue had become one of public concern.
You had said during the course of your testimony that a bargaining chip was offered by Wentworth Douglas Hospital, in which it would offer or accept discounted rates from Anthem in terms of payment for those services if Anthem could increase volume to its doors. Is that correct? Did I interpret that correctly?
I'm just going to object. That mischaracterizes what this witness previously said based on what he heard in the public.
Right,
perhaps you could explain again what you meant when you talked about a bargaining chip, a trade-off with respect to Wentworth Douglas Hospital.
I was talking about the inducement to accept lower reimbursement rates that a carrier may create by delivering a greater volume of patients.
And so with respect to that particular element, is that something you learned through public discussion about this issue? Through testimony of Lisa Gerton, for instance, or was that through discussions with Anthem?
No, I learned that through research of the literature on what's going on in health insurance markets.
But as it applies to Stratford County,
I know nothing, specifically about the bargaining process between Wentworth, Douglas, and Anthem.
okay. Now, with respect to, for instance, Manchester, there are 2 hospitals right in Manchester that are part of Anthem's network. Wouldn't you agree that the same logic should apply there that applied in Stratford County if that was going to be Anthem's approach?
You're going to have to bring relevance in here, that you're straying Stratford County issues to do with Stratford County.
I also think that, Commissioner, that this is beyond the scope of the direct examination. There was no discussion about Manchester.
I'll move on, Commissioner. You were talking about how, would it be appropriate for me to characterize the application of Insurance Department Rule 2701 as kind of an off-the-shelf standard that was applied to ensure network adequacy for qualified health plans? In other words, you had this existing framework and you decided to use that to determine network adequacy under the ACA?
We used the existing framework with a modification.
And again, what was the modification?
That we would make a reasonable assumption about the number of covered lives that were going to exist in the future under that policy being sold in order to apply the geographic accessibility standards.
Yeah, I wanted to ask about that actually. You said you wanted to assume an enrolled population looking into the future. Who made those assumptions? Was that the department or Anthem?
My understanding is that the department asked Anthem to use a reasonable assumption, and they came up with the idea of using their entire existing enrolled population in the individual and small group market, and we accepted that as reasonable because we felt that that was a much larger number than the number of people who are likely to be enrolled in this plan.
And was data submitted from Anthem on a county-by-county basis talking about how many people would be part of that population?
Yes.
Okay. And so was the adequacy standard that applied to whether Anthem's market was, its new market, its narrow network, was adequate, predicated upon the old, I'm just trying to understand, predicated upon the old network of hospitals?
No, just the existing number of covered lives.
Okay, so when you said earlier that you required Anthem to show that their existing market met adequacy standards, you're talking about the existing number of lives that are covered at present by its other policies.
Yeah, I don't remember saying that, but I don't know what that means.
Well, that was your testimony earlier. I wrote it down. You don't recall saying that?
If you want to repeat it.
Well, I'm just trying to
make sense of it.
clarify, because you had said earlier that you required Anthem to show that their existing market met adequacy standards.
The existing market?
Yeah, I didn't understand it. So I guess what I'm asking you is, when you talked about a patient population that was to be assumed, the assumed population would be the population that was presently, or then presently being covered by Anthem's various policies?
Yeah.
Okay. So with respect to that, had Anthem previously submitted consumer surveys, for instance, that detailed the extent to which people in those counties were getting access to their primary care providers?
I don't know.
You
You should ask the next witness. He'll help
So
you
you
with
don't
that.
have any knowledge?
Right.
Okay. Regarding the NCQA standards for waiting times, for instance, I will represent that the certificate that was provided as Exhibit G in this case wasn't produced in response to our RSA 91A request. And so I assume then that the department didn't consider that as part of its network adequacy analysis. Can you confirm or deny that assumption?
No, that wouldn't be a safe assumption.
Are you aware what the waiting time standards are that have been established by the NCQA for primary care access?
Object to the form. This question assumes that there are such standards established.
Well, let me go back to what the 2701 requires. Is it not the case that the insurance department regulation requires that any plan on under that regulation meet waiting time standards established by the NCQA?
Yes.
I want to object to the form because I think that mischaracterizes what that section says.
Would you agree that 2701.07A requires that waiting times for patients on the network not exceed standards determined by the National Council on Quality Assurance?
I'm going to object. If you're going to ask questions about it, this is a long, detailed rule. If you're going to ask specific questions, Commissioner, about this rule, I would like the witness to have an opportunity to have the rule in front of them. Now it's just a bad paraphrase. I have the rule right in front of me. I don't know what he's referring to. I think it's very unfair to the witness. So just as a fairness thing, put a copy of the rule in front of the witness, please, if the Commissioner would so order.
Let me ask it this way. Are you aware whether any waiting time data was submitted by Anthem as part of its application?
I don't know.
You'd spoken earlier about mileage standards and the fact that 100% of a population in a county doesn't have to be covered within those mileage standards. Is that right? 90% of the population of that county has to be covered by those mileage standards.
Correct.
So if you had a county where the assumed membership population that was covered by those mileage standards was only 85%, that would not be a network adequate county, correct?
Correct. Unless there are exceptions built into the rule. For example, if it involves a situation where the insurer has made a commercially reasonable offer to the provider, then that's one exception. I think there's a reference to centers of excellence. So there are a number of exceptions, but if we're talking about the general rule, you're correct.
Okay. Can we agree that those exceptions weren't invoked in this case for Stratford
Yes.
County?
Yes, that's what I think.
Are you aware, you also spoke about travel time standards, so that the provision that you're talking about has a mileage standard as well as a travel time standard.
It's either or.
Right, either or. Are you aware whether Anthem submitted any data concerning travel times?
I don't know.
You said that one of the dilemmas that the department was facing was that you had to make a prospective analysis of
Right.
a plan that isn't in place yet. Now, you were aware throughout the department was aware throughout the time period that it was evaluating the network adequacy of the pathway network, that it was the only plan being evaluated at that time. Is that correct?
Right. We were aware that that was the only plan we had in front of us at the time.
Okay. And you had spoken about 2 other potential multi-state plans that you had been counting on, but that didn't come through, right?
Well, we were hoping for at least one multi-state plan to come through at the last minute.
Did any of those plans submit any kind of network adequacy filing or any paperwork relating to an application for approval as a qualified health plan?
No, the process for approval for multi-state plans isn't the same as our QHP process. OPM maintained that it had more control over the certification. So,
For those entities?
yes, for the
Okay.
multi-state plans.
So I'm just trying to get to the basic question of, at the time that Anthem's plan was being considered by this department for network adequacy, were there other plans being considered simultaneously, or was Anthem the only one?
Anthem was the only one.
Okay. So at the time that network adequacy was being evaluated by this department, the department knew that it was the only plan being considered at the time.
We knew that it was the only plan we were looking at the time.
Okay. Would you agree that the Affordable Care Act has a goal of not just lowering cost?
Yes,
Would you agree that one of the goals of the Affordable Care Act was to extend coverage to the previously uninsured population?
I think that's the most important goal of the Affordable Care Act.
Would you agree that, generally speaking, the lack of health insurance coverage was a serious, maybe even the predominant impediment for a user's access to health care?
Yes.
And by extrapolation, then, would you agree with me that one of the goals of the ACA was to use health insurance as a means to an end? In other words, to provide access to health care?
Absolutely.
In pulling the managed care regulation off the shelf to use under these circumstances, was there any discussion inside
I'm objecting to the characterization of having pulled this off to the shelf. This is an existing law enacted by the legislature in 420J in this state, and characterizing it in that way that we've gone into the cupboard, I think really is, it casts a very, I'm trying to say this in a polite way, but it really disparages the public function that's involved in the legislature and governor passing a law, and this agency trying to apply the law to the best of its ability. So I object to the form of the question.
Mr. Commissioner, I would also object that once again we are far, far afield from what the purpose of this adjudicative hearing is. We're also well beyond the direct examination of this witness. Getting into a lot of the public policy arguments that have been specifically excluded from relevant evidence in this case.
You need to keep it relevant, please.
Regarding the authority of the department to address a gap or an issue with network adequacy, you agreed, I think, with Mr. McCaffrey that the department has no power to order Anthem to contract with a particular provider, is that right?
Correct.
But the department does have the power, if it identifies a gap in network adequacy, to order Anthem to take steps necessary to remedy that gap, correct?
Broadly understood, that's correct, in the sense that one of the steps is always to cease marketing the product in that county.
One of the exhibits that you were asked to look at, I think it's Exhibit F in the book in front of you, page 228.
Yes.
Under the portion of the table there that says New Hampshire Insurance Department certification procedure, it says issuers of medical qualified health plans must comply with the New Hampshire Code of Administrative Rules, Part INS 2701 for network adequacy. You had said earlier that there was a prospective aspect to your analysis that made it impossible to apply certain elements of those standards. Is that
Right.
a fair characterization?
Yes.
But it doesn't say in here that that's going to be the department's approach, right? It just says they
Yeah.
have to comply with 2701, correct?
Right, right.
With respect to the assumed member population that you had discussed earlier, was there any requirement that Anthem submit location data as to those assumed members?
Yeah, I think that is part of the geo-access report.
And I guess I just want to confirm, you're not aware whether any of that data was actually submitted?
Yes, I think it was.
Oh, okay.
But again, this is an area where the next witness will
I
be more
understand.
helpful to you.
Yeah, thank you very much. That's all I have for now. Thank you.
Thank you. Any further questions of this witness?
I have none. Mr. Commissioner, I think I do have just a couple of questions. That's all right.
A couple of questions.
May I proceed?
Yeah.
Mr. Feldtable, let me just begin kind of where council ended, because you were being asked about Exhibit F, which is the bulletin.
Yes.
And I'm correct that if you look at page 2 of the bulletin, so I'm not sure what the Bates number on that is. Can you just put that in down at the bottom of the right-hand page?
Yeah, that's 225.
So looking at 225 in the first full paragraph, it does say that in reviewing proposed QHPs, the department will apply all state regulatory standards except those that are inconsistent with or would prevent the application of federal law. And would you agree that that language gave the department the discretion and leeway to take a statutory framework, a rules framework that you've described that doesn't quite fit with what it's now being tasked to do by the federal government, give some leeway and some discretion on what can practically and reasonably be applied to this type of a situation?
Yes, and RSA 420N also contemplated that kind of situation where if a state law or regulation prevents the application of federal law, then the commissioner had the authority to implement the state law differently. Yes.
I mean, after all, the Affordable Care Act was trying to get coverage on the exchange for citizens of New Hampshire, right?
Yes.
And that's certainly one of the overriding goals of that federal legislation, is to try to get carriers to put out products that are network adequate, but that provide insurance coverage for people that need it.
Yes.
And all you've testified to is that what the department was faced with was a unique situation where their existing framework didn't quite fit the job that they need to do with regard to network adequacy. Is that fair to say?
Yes.
And I think you've also told us that unfortunately, whatever the circumstances, the federal government didn't give you any specific guidance on how you would undertake this important but unique task of
Yes.
Other than through your own existing structure.
Right, and specifically on network adequacy, they deferred to the state standards.
And on these issues.
Well, you're not done.
No, I'm almost done though. But
Okay.
So on the issue of the prospective versus a retrospective review, is it fair to say what you were explaining is that because you were undertaking a network adequacy review prospectively, before there was a plan was certified, before it was sold, before there were actually members, because we have to remember that these products weren't going to go into effect until January 1st, 2014, right?
Right.
That's the effective date. Then because of that circumstance, some of the requirements, the traditional requirements under 2701 simply couldn't be done.
Right, not prospectively.
Prospectively, you mentioned the consumer surveys,
Yes.
whatever that issue might involve, anything that had to do with specific wait times. Those things, whether the department was going to traditionally require them or not, couldn't be done in this situation. Is
Correct.
that right?
That's correct.
And am I also correct that if you want to look at 2701 strictly, like counsel for Ms. McCarthy apparently wants this hearing officer to do, that by the very terms of those provisions, they only apply if a carrier has at least 1,000 members in any given county. Isn't that right?
That's right.
And so as of July 31st, 2013, when the department made the decision to recommend Anthem's plans for certification, as of that time, Anthem had no members in Stratford County. Is that correct?
Right, and that meant they technically met the network adequacy standard, but we didn't apply it that way.
Right, because it was an unusual situation.
Yeah.
But what I'm simply talking about is counsel for Ms. McCarthy seems to be suggesting that the department didn't do its job because it didn't hold Anthem to the letter of every provision in 2701. And if they're going to take that view, then the provision that says there's network adequacy anywhere other than when there's 1,000 members in a county should also apply.
Yes, that's how we would look at it.
Okay. To try to accomplish what the federal government wanted New Hampshire to do as its partner in connection with this new exchange, the department gave consideration to what its existing structure was, decided how it reasonably could go about conducting a network adequacy review under these unique circumstances. Is that fair to say?
Yes.
And the focus of that, as I think you've indicated, was on the geo-access.
Correct.
Because the one thing, the piece of the network adequacy analysis that you could undertake had to do with the providers, because that was a network that was being built by Anthem.
Right, that's the one thing we knew about at
Yes.
that point in time.
On the member side, you didn't have any of that data because, of course, you couldn't have it until the products were sold. The coverage became effective January 1, and members actually started using the products. Is that fair to say?
Yes.
Are you aware of any authority that the insurance department would have to reverse the certification that was undertaken by the federal government in connection with the Anthem plans for the exchange?
No, I don't think we can reverse the federal government's certification.
And to your knowledge, in the process that began from the April 10th, 2013 bulletin, Exhibit F, up through July 31 when the commissioner made his recommendation, Did Anthem comply with all requests from the department and provide whatever information or materials that were requested to assist it in conducting its network adequacy review?
Yes, from my knowledge, Anthem supplied everything we asked for.
I'm almost done.
Oh, I won't believe you next time you say couple. Couple to me means two. Go ahead.
And again, there was references to, you know, the goals of the ACA and how that was implemented in New Hampshire by the department. And is it fair to say that really what things boil down to in these circumstances is attempting to balance affordability and access?
Yes, that's right.
I want to just mention, in terms of the NCQA accreditation, whether or not there was specific review of the exhibit, I think it's G, of that certificate, is it fair to say that the department had the knowledge when it began its review of the pathway networks that Anthem was fully accredited by NCQA?
Yes.
Without looking at a specific, that specific document and whether it was, in particular, was part of the review that would become part of that paperwork. The fact is that the examiners looking at this network adequacy review were aware that Anthem's was fully accredited at that time.
Yeah, they would have lots of ways of knowing that.
Okay, if I might just have one. Okay, all right, thank you. Thank you very much.
Is there anything?
Nothing further.
Thank you. We'll take a half-hour break and return at 1:15.